Hello, good morning everyone. This is our first time to start in our channel MRCB review. So this is planned initially for everyone who is planning to take MRCB, the first part, and he's in a hurry and exam is about. So we will just try to concentrate on the outlines and the very important notes that most probably it will be available in exam. So the first thing we will start on nephrology. Okay, start with just different topics and just we will concentrate one line or more in each disease or each point. So now we will talk about malignant hypertension. It will be presented by the characteristic hyperplastic atherosclerotic onion skin appearance in the arterioles. For the cardiogenic shock, typically it will present with patchy tubular necrosis. Regarding the IgA nephropathy, it occurs in young adult male, age around 20 to 30 years. Typically, it occurs within 12 to 24 hours of pharyngitis. It will be accompanied by loin pain, muscle pain. Prognosis is usually good. 25 to 50% will have in this stage renal failure. If we compare it to post-streptococcal glomerulonephritis, the difference is that post-streptococcal glomerulonephritis, it will take weeks to occur, and also it will be characterized by low C3 and low C4. If we try to compare this to microscopic polyangiitis, it will take long period to as prodromal symptoms. Now we will talk about interstitial nephritis. It causes inflammation and edema. If untreated, it will cause fibrosis. It can be diagnosed by renal biopsy. Usually 60 to 70% of cases will be caused by drugs. The mechanism through it happened, it is delayed T-cell hypersensitivity or cytotoxic T-cell reaction. Cytotoxic T-cell reaction or delayed T-cell. The commonest drugs that are causing interstitial nephritis include, start with antibiotic, beta-lactam, including methicillin, sulfonamides, non-steroidal, diuretic like thiazide and furosemide, antiviral like acyclovir and fosicarnate, and allopurinol and cyclosporin. The clinical presentation, I think it seems to glomerulonephritis, fever, maculopapular rash, arthralgia, mild eosinophilia, and if we find eosinophilic urine or eosinophiliuria, this will be basogenomic. Corticosteroid will be beneficial if it can be started early. The prognosis is good. Usually there is partial or complete recovery. Another topic is that we will try to differentiate between the different types of biliary effusion according to the cause. Uremia typically will cause exudative biliary effusion and it will be fibrinous. This is pericarditis. Uremia will cause fibrinous pericardial effusion. Tuberculosis, metastatic tumors will cause hemorrhagic pericarditis. Collagen vascular disease will cause serous pericarditis. Medullary sponge kidney, it is a disorder which can affect part 1 or 2 kidneys. It will cause ectatic, cystic changes of medullary and papillary collecting system. It can cause pyelonephritis and renal tract obstruction. It is a developmental abnormality. Most of the cases are sporadic, but there is also a rare variant which is autosomal dominant and familial. It will have its onset in adulthood. There is also juvenile autosomal recessive disorders. Polycystic kidney disease is similar. It has autosomal dominant inheritance in adult, but in infantile form there is autosomal recessive. The nephrogenic diabetes insipidus is X-linked. Albert syndrome, it will cause nephritis, hematuria, progressive renal failure, high frequency nerve deafness, and usually it will be more marked in males. Reflex nephropathy, usually it is we can say that some environmental factor has effect and also some genetic factors, but still the exact genes are not yet identified. Regarding membranous nephropathy, typically it will present with thickened basement membrane and granular cast deposit of IgG and C3. IgG and C3. It will present in those age 40 or more, male most commonly 2 to 1 male-female ratio, and is associated with variable prognosis. 25% will have end-stage renal failure within 10 years. 25% will have remission. There is high rate of remission, especially if it is idiopathic form. It will present usually as nephrotic syndrome. Nephrotic syndrome is rare. What else? That's all.